are talking HIE and cerebral palsy today. And you have done an incredible job of dedicating your career to research, and I would say you're a strong advocate in the space for a lot of the things that I think our community in particular has seen as issues, barriers to getting diagnosis and things like that. So I'd love to start with you to just give an introduction about, your specialty and, kind of your path of research and, clinical work and all of that.
Yeah, so hi everybody. I'm a pediatric movement disorder specialist at WashU, and I do spend most of my time in the lab, and I research in mouse models of neonatal brain injury, so mouse models of HIE. I look at what are the features that cause a movement disorder called dystonia, which can be a really common movement disorder that you can get as a part of cerebral palsy after HIE. So that's my research focus. And then clinically, I spend all of my time in the Cerebral Palsy Center at WashU. So taking care of kids with CP, a lot of whom have had HIE and a lot of whom have dystonia. So my path to here, my research in grad school was on Parkinson's disease because for personal reasons, it affects my family. And when I started med school, I just realized I really loved working with kids. So I thought about movement disorders in the context of kids, and the most common motor disability in childhood is cerebral palsy, and there just aren't, we need more researchers studying it. So I felt called to study that.
Yeah, that's amazing. And we know that, dystonia in particular comes up often in our community of, it tends to be one of the trickier ones to treat successfully and get control, to really give kids a break from this involuntary movement that can, impact so much on their quality of life. So yeah, that's, it's so great to have you joining us and joining our medical advisory board and, just all the work that you are doing in this space. So I'd love to start and talk about, I know that you've been talking a lot about this diagnostic journey, and, in particular, I know there's a push with like the CP Foundation and all sorts of other, advocacy groups, and it's a multidisciplinary approach, which is really nice, to looking at how we can get quicker diagnoses and more accurate diagnoses and things like that. So do you want to talk a little bit about the history of, I guess where that's been and where it's going?
Yeah, so I think the concept of making a CP diagnosis or understanding of when to make it has evolved quite a bit, maybe in actually the last 5 years or so. So I think there is a balance between wanting to give a diagnosis when you're absolutely sure that that is the diagnosis. And I think some people historically maybe would have delayed a cerebral palsy diagnosis until you saw how a child who maybe had HIE, who clearly was at risk for developing cerebral palsy, saw how their motor symptoms evolved over time, and then maybe later on in childhood would officially get that label of cerebral palsy. But that has shifted, and that balance has shifted quite dramatically. And I really want to credit Yona Novak and a really landmark paper that came out in JAMA Pediatrics a few years ago, pushing the value of an early diagnosis of cerebral palsy, particularly in children who we know are at risk. So children born premature and children who have had HIE. And there are certain features that she pointed out. So features on brain imaging, features on the early movement exam using certain standardized motor exams like the Practical General Movement Assessment, for example, that can allow you to make a prediction with pretty high accuracy of when a child is going to meet criteria or whether a child has cerebral palsy or not. So the push for making the diagnosis has shifted from, maybe 5 or 6 to even a year or less old. And the value of that is huge, because if you think about getting a cerebral palsy diagnosis and the access that provides you to this huge, large community of people with cerebral palsy, just in terms of support and infrastructure, the access that provides you in many of our states to early interventions and first steps and therapy services that you kind of automatically get if you can check that cerebral palsy checkbox. And also just an understanding of, okay, now I know my child has a non-progressive motor disability. Being able to have that label, I think, can give families some sense of closure almost, like these are the symptoms we're dealing with. What are the next steps? As opposed to leaving people in a limbo, in a diagnostic limbo. Mm-hmm. So I think for all of those reasons, we're realizing that an early and accurate CP diagnosis is critical for the well-being of our patients. So yeah, I push for it, and I push for it standing on the shoulders of giants. So yeah, I'm really grateful to have come into the field at a time when we know more about the value of an early CP diagnosis.
Yeah, and it has been so, honestly, I mean, I've been in this community for almost 9 years now, and I can see anecdotally, kind of this clinical shift too. I mean, there's certainly still people out there saying, I don't want to diagnose before age 2 to their patients and families when there might be a very clear cerebral palsy diagnosis coming. But, I think when we continue this messaging around early intervention, and the earlier that you're addressing things and, getting them the tools that they need for our kids to, reach their own wonderful individual potential, the better. We know that, it's researched, and so what are these barriers to care? And it's so great to hear that this is one that is, being knocked down, and we're seeing such a shift in that arena. Because I know that's a question that, especially the first year or two for families in our community, they're like, why is this, why are they hesitant? Like, we know that they're, my child is not meeting, gross motor milestones. They have spasticity. They have, like, these are things, and then if it's not to say kids can't progress through that, but that's the whole idea, is to get them, into therapies that can help them progress.
Yeah, absolutely. That's such a critical point. This isn't just, it's not just the social aspects of the benefit of the diagnosis. It's a real medical benefit. You're having a cerebral palsy diagnosis early and intervening early. There's clear evidence that leads to better outcomes. So that's a critical point. Providing a diagnosis early is better really across the board.
Mm-hmm. And then I want to kind of shift into the next part of the spectrum, which you have also, I know, spoken about a lot, is the transitions of care into adulthood. And we talked with Ed Hurwitz, who's also our medical advisory board, and he's a PMR physiatrist, and he talks a lot about how do we manage, kids that grow into adults with CP. And so I know you're also in this arena from your perspective and your, expertise. So I'd love to hear kind of, a synopsis of the work that you're doing in that, because that's a huge, obviously for our families too, they're thinking ahead of, and we have a lot of families who are recently transitioned from pediatric to adult medicine. So, what is that space looking like?
Yeah, so this is something where I am passionate about, but a relative novice, because I come from a pediatrics background. And sadly, our training doesn't involve a lot of training on the manifestations of pediatric disease in adulthood, which in and of itself is a huge area for advocacy. I think we need to be trained more in anticipatory guidance for our patients, for our kids, in terms of when they leave our clinics, do we just send them out without telling them what to expect? I feel like we are responsible for knowing what the issues are that kids with CP need to face when they become adults with CP. So in kind of inspired by my lack of knowledge in this area, I worked with several people, including Ed Hurwitz, about figuring out what the literature was in the area of neurologic concerns. Myself, I'm a pediatric neurologist, so I focused on what are the neurologic issues that face adults with CP. And there were a couple of things that I think many adult neurologists would think are surprising. So the increased risk of stroke, the increased risk of spinal cord compression, and how those features that you might see that are clearly neurologic issues in adults with CP can impact their mobility, can impact their fatigue. And I think when we talk about adults with CP, we say, or when physicians or even when adults with CP think about themselves, they think, oh, I'm just a little more tired today. It's probably just my CP. Oh, I'm not walking as well today. It's probably just my CP. But I think we can do better. I think we can figure out what are causing these issues. At first by generating clinical interest, and then also by generating a lot of research interest to try and help adults with CP and say, I don't want people to say it's just anything. I want people to live their best lives. And if we don't focus on these issues, we can't give people that outcome. So in the paper that we published recently, we talked about these features, and then we talked about what neurologists need to know, what researchers need to research, and we also talked about what adults with CP need to know to advocate for themselves, because we're in a little bit of a vacuum as we transition from the pediatric sphere to the adult medical care sphere. And unfortunately, we're relying on adults with CP in a lot of ways to advocate for themselves. And if we don't tell them how to do that, they can't do it. So that was a huge focus of our paper as well.
That's amazing. Yeah, that is obviously a big gap. And I remember, I've listening to adults with CP speak about that. And I have a friend locally who I grew up with who has spastic quad CP, and he's like, I'm still seeing the same PMR that I grew up with, which is fine, but like because there's no one else, there is definitely has been a gap of care. So I think that's just such important work, especially as our families continue, on through this continuum and, have, kids that turn into adults across all sorts of different outcomes and, levels and all of that, and helping everyone, work together on this next phase to build the resources that are needed out there for sure. That's such important work, and I'm so glad that to hear that it's being done and that you're a part of it. It's wonderful. And I know our families will be happy to hear that too. So let's talk a little bit more about your research into HIE and dystonia and what you're seeing and what you're hoping to crack out of that, and maybe even a little bit about what parents should be asking about when talking to their physicians about their child's dystonia and treating that.
Yeah. So I think the main issue that we generally hear, or that I generally hear from families in clinic, is when I talk to them about their dystonia, is that these will be kids that are 10, 11 years old, is that nobody's told them that their child has dystonia. So it is very difficult, I think, to diagnose dystonia in a child with CP, particularly a child with CP after HIE, because I think you have a mix of different kinds of tones. So you have a mix of spasticity, which is quite common across the board in people with CP. And then you can have dystonia superimposed on top of that. And it can be very difficult to say what is spasticity and what is dystonia. And so kids are treated for spasticity, and it's not really fixing their dystonia. And so it can be tough. It can be tough to see your child struggle with movements and not know why the treatments that may be more spasticity focused are not necessarily working for them. So diagnosing dystonia and doing it early, I think, is a huge push that I want to focus on. And a large part of my research, so I have an animal-based lab and I have animal-based and patient-based research. A huge chunk of my research is focused on how to optimize dystonia diagnosis in patients using in a quantitative way. So right now we diagnose dystonia, most people diagnose dystonia by kind of by in a subjective way, by looking at the patient, by looking at their exam, by saying that, okay, if I do this maneuver, this happens, and I think that's dystonia. And that's fine, but it takes a lot of skill and a lot of training to do that. So I'm trying to figure out a quantitative way to do that so that across practitioners, across centers, there's a consistent way to diagnose dystonia. And then I'm trying to take those same measures and apply that to animal models of HIE to see if we can diagnose dystonia in mice in the same way, and then use that skill set to figure out what are the specific injury patterns and patterns of neurotransmitter imbalances and that sort of thing that leads to dystonia. So I think the first big thing to attack, the short answer is the first big thing to attack is making dystonia diagnosis easier and more objective. And I think we can do it. I think it's definitely possible. And I think there's a huge passion for it in the field. So I'm looking forward to getting it done. I think it's definitely doable.
That's great. Yeah. And so that is something that sounds so fascinating too, that you have mouse patients and your human patients, and seeing how you can, move this forward, with all of what you're doing. And again, we are so grateful that you're doing this work. It is going to make and is making a direct impact on our community. And just sharing this knowledge is so important. It is HIE Awareness Month next month, which follows Cerebral Palsy Awareness Month. So we're kind of getting all of the information out that we can about all the things. So let's see here. Oh, this is a good question that I think we might want to, this follows right along with questions that we should be asking. As a parent, what are some signs we should look for to identify dystonia versus spasticity?
Yeah, great question. So spasticity tends to stay pretty stable over the course of the day. So the amount of tone you have when you're asleep may be a little bit less than the amount of tone you have when you're awake. But things like getting really excited or trying to make a movement shouldn't necessarily change the amount of tone you have, meaning that if you're tight when you're at rest, you should be the same amount of tight when you're trying to make a movement. You may be a little bit less tight when you're asleep, but the tightness should still be there. That's spasticity. Dystonia is highly variable and is triggerable. So if you feel like your child, when they're at rest, can be quite loose, but as soon as they get really excited, they get really tensed up, or their arm twists back, or their legs turn in, or as soon as they try to reach for an object, an arm that may be pretty easy to move around when they're relaxed, but as soon as they try to make a movement, their arm twists up. That's dystonia. So it's that variability of movement and the triggers. So a voluntary movement trigger, trying to move, an excitement trigger, so getting really excited and then you get really tensed up. That's more dystonia than spasticity. I think one of the reasons it's so hard to diagnose dystonia in like a 20-minute clinic visit is that often you bring a child in, they're stressed out the whole time. This isn't their normal day-to-day atmosphere. I mean, coming into a hospital is very stressful, particularly these days. So a high stress environment may make them have activated their dystonia the whole visit, and it doesn't look variable in the clinic. So as a parent, I think looking for these features, this variability, and communicating that with your physician can be a good clue that there's underlying dystonia, maybe in addition to spasticity in your child.
That's such a great point. And I think, we try to educate families, in particular around seizures, to capture things on video, right? Yes. And this is I think this can be translated over to this as well, where if your child, to your point, if a child is, stressed out, or, it's a different situation and they're constantly on, and you don't have that variability, it's very, like you said, it's very difficult to assess, where this might be an opportunity for families to capture, the differences on video and give that as a fuller assessment of the child.
That's a great suggestion. And if you look at what we as movement disorders physicians do when we're trying to figure out what kind of tone people have, we sit around and talk about patient videos that we take. So providing videos, that's the best currency for us as movement disorders physicians. So yes, bring in all the videos. We love the videos. Do it.
That's great. That's so good. Yeah. And I think that's an actionable thing that we can give our community, is just to, as we start looking at cracking this code. There's one more question that's coming in, and then I think we can wrap up. But asking about the general treatment options for dystonia, meds and therapies and things like that.
Yeah, so this is a huge area that needs more research for sure. I think in the context of HIE, a lot of the treatments we have, there have been a series of reviews published where a lot of the treatments we have don't have great evidence behind them. So treatments like Artane, trihexyphenidyl, which have been commonly used for dystonia historically. There have been many meta-analyses, including a big Cochrane meta-analysis recently published that shows that it actually may not be effective for dystonia. Medications like carbidopa, levodopa, Sinemet, that have been used for genetic types of dystonia have variable effect in people with dystonia in the context of HIE, dystonic cerebral palsy. There are other treatments that are having growing evidence, so they need to be researched more, but I think are being used more frequently in the clinic to good effect. One of those is in kids with dystonia and cerebral palsy, like a lot of our kids with HIE, using high-dose gabapentin can be helpful for dystonia, particularly in kids that have a lot of pain associated with their dystonia, because pain can trigger dystonia, dystonia can trigger pain, and you get into this vicious cycle. So gabapentin in those kids has been shown to be helpful. Clonidine can be helpful. And particularly in kids that have a lot of mood instability during the day, or kids that have a lot of trouble falling asleep at night. A baby dose of clonidine in the morning, a slightly larger dose of clonidine at night can be really helpful. A clonidine patch can be helpful. That gives you a steady dose throughout the day. Medications that are good for spasticity are also good starter meds for dystonia. So baclofen can be helpful for dystonia. Sometimes benzos, and particularly medications like clobazam in kids with seizures. We see a lot of additional benefits in kids with tone problems, particularly dystonia. And then thinking about surgical options and what surgeries are good for dystonia or can be good for dystonia, and what surgeries are definitely not. So there's identifying dystonia before going for a surgery like a selective dorsal rhizotomy, which is useful for spasticity, is really important. Because there is some evidence that if you have a lot of dystonia, you may not be a good candidate for that surgery. Deep brain stimulation for dystonia, picking the right candidates for that and doing it early can be really valuable, which means identifying dystonia by the time your child is 7 or so, by the time you're an early candidate for DBS. And then thinking about intrathecal baclofen pumps, which are done at some centers for dystonia, but instead of putting it lower in the back, which is where you would do it for spasticity, some centers put it higher in the spine with the idea that baclofen can go up to the brain that way and help with dystonia. So a lot of the surgical treatments for dystonia are gaining traction. All of these treatments need more research, but identifying dystonia at the outset is what helps people figure out which of these treatments to institute. So more research needed, but lots of options.
Yeah, it's interesting. I used to work in the adult movement disorder space with, marketing and communication. And so talked a lot about primary dystonia. So and seeing the difference in our community, and when families say, yep, we're trying all these different things to try to mitigate, and Artane, and like you said, they've been proven for primary dystonia, but not necessarily effective in our community. And I love just like talking through the opportunities of these different medications and surgical options that are showing promise. DBS, deep brain stimulation, is one that, I again saw a lot of benefits in the adult population of, primary, in the clinic that I worked for. But it's so interesting. I think there, this next 10 years of neuro research with implantables and things like that, I'm really eager to see what, how that can benefit our community, truly.
Yeah.
So, yeah.
And I think it's nice important to note, so a lot of research is focused on people that have, a single gene cause of dystonia with regards to dystonia. And I think it's easy to conceptualize that. So this person has this mutation to this gene, and so they have this dystonia. But those are very rare causes of dystonia ultimately. And we see them at large centers, and we have those patients, and it's a huge blessing to see them improve with the treatments that work for them. But by far, the most common cause of dystonia in childhood is cerebral palsy. Mm-hmm. So it is a blessing to see that attention is being focused on this population, because if the biggest potential for impact is working with this community and addressing the needs of this community. It's a really exciting time, because I think that people are realizing that more and more now.
Absolutely. Well, I want to thank you. I think that's it for the HIE and CP questions for this morning. I want to thank you for serving on the medical advisory board with us, for all the work that you're doing. It is, incredible to see your passion and your expertise in this area, to help ultimately help improve the quality of life for the children and families that you work with, and then, the community out there more widely. Thank you for taking the time today. And thank you everyone who's been tuning in and asking questions and following along. This will be available afterwards, across our social media sites and our website. So you'll be able to access this, and we'll, come up with some bullet points from, in particular, the talking points about, questions to ask and, available treatments and options out there right now. Well, everyone have a great day. Thank you so much, and we'll talk soon. All right.
Thanks, Betsy. Thanks, everyone. Bye.